Good evening, everyone. Welcome to today's session. We're going to give it 5 minutes so that the rest of our participants can join. Alrighty, we're going to go ahead and get started. Good evening, everyone. I hope you can hear me. If you can, could you please just put a thumbs up?
We can hear you.
Fantastic. So, welcome everyone to the fifth edition of our online webinar series for the SU Africa Global and Public Health Student Network Initiative. Today, we will be tackling the global health priority of knowledge translation. Before we carry on, I just want to give everyone a couple ground rules and housekeeping. We ask that when you are engaging with us, to keep your mic muted. So when you log in, just double check at the bottom left corner that there's a line striking through your microphone. If you have questions, we have people in the chat to notify the moderators or the speakers. So simply raise up your hand by clicking the button and we will take your question either during the question and answer session or at the end. Next, if you have any questions, feel free to type it in the chat and we will answer or ask the speaker to answer during any of the designated sessions. Like my colleague Vanessa has mentioned, please also just introduce yourself in the chat so that everyone on the call knows who you are, where you're from, and what you're currently doing. Without further ado, I'd like to pass on the baton to Vanessa to introduce the initiative.
Thank you so much, Tolu. Good evening, everyone. My name is Vanessa, and I'm one of the students who are involved in the core team. I'll briefly be giving an overview of the initiative. So the SU Africa Global and Public Health Student Network has been created with the hope of building an African global and public health network, a community of practice that is student and youth focused, and it's aimed at enhancing the knowledge, practice, and skills regarding priority and also current future global and public health issues relevant to the African continent. The whole point of this initiative is to help create a generation of change leaders and change agents, and to co-create this project with students and build a network into Africa by sharing learning experiences. So the reason this initiative was formed is due to the need that came up. So a lot of students at Stellenbosch University brought up the need to have this community of practice and exposure to different leaders and practitioners so as to be capacitated and inspired in order to be the next generation of global health leaders. And also, COVID-19 showed us that despite inherent challenges and global power asymmetries, Africa has a capacity to respond to global and public health crises. And therefore, it's essential that we take the lessons that we've learned from COVID and we take this desire and this need from students who desire to learn and be part of the next generation of global health leaders and actually provide them with the capacity that they need. So in terms of the context of this initiative, it's a combination of the Africa Union and Africa CDC who have prioritized public health on the continent. The new public health order for Africa seeks to address deeper structural public health deficiencies at a national, regional, and global level. And we hope that by knowledge impartation and skills development, we'll be able to help contribute to achieving this public health order for Africa. So I'll be briefly introducing the core team. So the core team consists of Prof. Renee English, who's the acting head of global health, the head of the Division of Health Systems and Public Health at Stellenbosch University. We have myself, Vanessa Annan, I'm a final year medical student. We have Hlakanipa Chalanga, who's a fifth year medical student, who's also part of the initiative, and Toluwani Adeboye, who is our third year medical student, who is our moderator for today. In terms of staff members, we have Stacey Blouse, who's a PhD student and a coordinator within the Division of Health Systems and Public Health. We have Welilia Dube, who's also a PhD student in the Division of Molecular Biology and Human Genetics, is also part of the core team. We have Dr. Juliette Nyasuru, who's a senior lecturer in the Division of Health Systems and Public Health. And we have Dr. Lynn Hendricks, who's a lecturer in the Division of Public Health, who's one of our guest speakers for today, who will be speaking to the topic of knowledge translation. And we have students who are across different African countries who are part of our network. So we have the core team in South Africa. We have students in Cameroon, Kenya, Sudan, Malawi, Uganda, Liberia, Nigeria, just to name a few. And we hope to expand this network in order to reach all African countries and build up capacity within Africa. Thank you so much, Tolu.
Thank you so much, Vanessa, for that lovely introduction overview. We will now be handing over to one of our students at our vast African network to introduce the first speaker for today.
Thank you. I will go ahead and introduce Ms. Cheryl Nam, who will be our speaker, one of our first speakers for today. So Ms. Cheryl Nam is a fifth year medical student at Moi University in Kenya. She's been actively involved in various student organizations, including the Federation of African Medical Students Association, the Medical Students Association of Kenya, and the Medical Students Association of Moi University. Additionally, she's collaborated with companies such as Lecturio. Ms. Nam is passionate about community service and volunteers with Respect, which is a youth-led nonprofit organization that It focuses on promoting sexual and reproductive health education amongst Kenyan teenagers. She's currently pursuing her studies at the University of Washington Global Health, where she is focusing on global health research. Furthermore, she serves as the Kenyan representative for the SU Africa Global and Public Health Student Network Initiative. Aside from her academic and humanitarian endeavors, Ms. Lam has a keen interest in entrepreneurship, music, fashion, and dance, reflecting her diverse talents and interests.
And now, without further ado, we welcome Ms. Nam to begin her presentation.
Okie dokie. Hi, Vanessa, can you hear me?
Yes, we can hear you and see you.
Okay, I dropped for a bit. I'm sorry. Let me try and share my screen. Okay. Can you see my screen? Is it visible?
Not yet.
Okay. Okay. Sorry. Okay. Now? Is that fine?
Yes, it's perfect.
Okay, cool. So sorry for that mishap. My name is Cheryl Nam. I'm a fifth year medical student, and thank you, Vanessa, for that introduction. And today I'll just be given a summary of what I've learned basically in the past 5 sessions. So basically I'll just give a glimpse of global health from a Kenyan student's perspective. And the first thing would be defining global health, which at the core is about achieving better health outcomes for vulnerable populations and eliminating health disparities in low resource settings. And it's very similar to public health, but emphasizes a multidisciplinary approach. And other than just focusing on preventive medicine, it also focuses on clinical care. So on the history of global health, some may argue that global health is just the newest iteration, formerly international health, which became international health, which was tropical medicine, and which was colonial medicine, and was developed to serve colonial interests rather than local communities. Thereby, you'd find features like a focus on infectious diseases. There's a neglect of health systems and social determinants of health, and lack of cultural sensitivity, as well as devaluing of knowledge of the local communities. Yes. And it's also said that the root cause of global health inequities is impoverishment from colonialism and slavery. And there is a global health divide between the global north and the global south. And this is due to different factors such as access to healthcare services, where there's a lack of financial resources and inadequate healthcare infrastructure in the global south. Under global health governance, the high income from high income countries. Then under health financing and investment, high income countries generally set the agenda and determine the funding priorities. Also, under access to medicine and technologies, the higher drug prices limit access to life-saving treatment, and wealthier countries determine the drug prices. Under humanitarian assistance and aid dependency, we have conditional aid being given. So aid is given to the global south with conditions and usually used as a tool to advance the political interests or gain influence in the global south. And finally, we have different health inequalities and social determinants, which are usually looked past, such as poverty, racism, gender inequality, and political instability. And as there have been very many great strides made in global achieving health in Africa and in Kenya. We have a decrease in morbidity and mortality due to malaria and HIV infections, as well as maternal and infant deaths. However, the global north is usually primarily concerned with communicable diseases. And as we are aware, in Africa, we are being plagued by other issues such as antimicrobial resistance and non-communicable diseases, particularly cardiovascular diseases, whereby in 2019, about 1 million deaths that were associated with antimicrobial resistance. And about 39% of all deaths in 2019 in Kenya were related to non-communicable diseases. So in one of the webinars, we talked about the effects of colonialism in South Africa. And today I thought I may just talk about it, the effects of colonialism in Kenya, as it's not something we talk about enough. So one of the things that happened during colonialism was the sidelining of African languages, with English being perceived as a language of empowerment. There was exacerbation of tribalism, where the colonialists exacerbated the differences between communities when there's a rise of consciousness. This created resentment and we see a trickle-down effect even today. Those displacements by settlers from of the citizens from the land by settlers, and there's a need to buy back the land with loans from Britain and World Bank after independence, which already made us dependent on the colonizer even just after we got our independence. Then on the education content, it majorly remained the same, and many Kenyans would attest to that our education history portrays colonialism in a positive light. There's also the banking concept, where the teacher is a depositor of knowledge and the students are depositories. And the teachers also tend to be very authoritative, and questioning things is discouraged, which leads to production of students who are passive and unquestioning, who end up not questioning the government or society. And on top of that, we also inherited the colonial government systems and the health systems. So in Kenya, there are several factors that have hindered the achievement of universal health coverage. And one would be inadequate health financing, whereby the Kenya's expenditure on health is 4% to 6% of the total government expenditure, as opposed to the 12% recommended in the Kenya Health Sector Strategic Plan and in the Abuja Declaration. We also have accountability systems and structures and wanton corruption in both the national and county government. You'll find at the national level, we have poor management with inconsistent allocations of funds to counties, and also delayed health insurance reimbursements to facilities. Then at the county level, you'd find that the county treasuries collapse facility improvement funds and grants that are meant for the facilities and appropriate them as county revenue, which cripples facilities and leads to inadequate resources and poor infrastructure. So about 20% of the Kenyan population have health insurance, which means 80% of Kenyans are forced to make out-of-pocket payments. And this discourages Kenyans from seeking health, And you'll find that many Kenyans come to hospital when they're in a dire condition. There's also inequity in distribution of human resources with shortages in the most remote parts of the country. And this is despite having over 4,000 employed doctors and over 1,000 posted interns. So as of today, doctors in Kenya were doing the 56th day of industrial action due to failure to implement the collective bargaining agreement, where the government was not holding the end of the bargain, and the demands, some of the demands were failure to provide comprehensive medical insurance, there's delayed posting and payment of interns, and an 80% decrease in intern salaries, unemployment of the 4,000 medical officers, and the overworked privately sponsored residents. So the government claims that the economy cannot support the remuneration of doctors, but we see lots of misplaced priorities, whereby there's a misuse of funds to do various things, like to innovate State House, the president's residence, and there's hundreds of millions being pumped into the office of the spouse of the president and the vice president who Kenyans do not elect. And there's also the issue of political cronyism and duplication of roles, whereby other friends of politicians are being put in power and being placed in positions such as that are duplicated, and the roles are sort of similar. For example, the cabinet secretary, the permanent secretary, and the chief administrative secretary of health, whose roles are really we don't understand why we need all these offices to do the same role. Yeah. So for the future of global health in Africa, we need strong leadership in the global south, with strong values such as integrity, accountability, and leaders who are committed to development and committed to improving the healthcare of the people. There's a need to keep the global north accountable, and this requires us to have a seat at the table, which also, again, requires strong leadership. There's a need to strengthen African economies because there's a saying that goes, whoever has the gold makes the rules. And therefore, we need to strengthen our own economies and be able to make our own decisions about the things that affect us. And there's a need to have leaders who are adaptable and innovative, whereby when different challenges come, we need to be able to adapt using technology and innovation. So our role as next generation leaders would be, first of all, this I got from Professor Heike Godold, who told us that we need to know ourselves, grow ourselves, and show ourselves. And the first one would be to know ourselves, where we need to have a self-awareness, being aware of our strengths and the weaknesses, and create a self-concept, even with leadership in mind. Then we also need to grow ourselves, where we need to have an avenue of self-development for both personal and professional skills, and learn different life skills such as critical thinking and problem solving, which are not part of our curriculum. So it's basically a challenge for ourselves. There's also a need to decolonize our minds and learn our history that is not whitewashed, and heal from the internalized oppression. There's also need to educate ourselves on research on health systems and health equity and social determinants, as well as the culture of the African people. So as we introduce new systems, we also have the community in mind. And it's important to also build your capacity through fora like this, the Stellenbosch Global Health Strengths Network Initiative. And lastly, we need to show ourselves, which means we need to continue advocating for equity in the health sector. There are many student-led campaigns that have actually worked. For example, in 2008 in the US, there was a Stop AIDS campaign where different groups, students included, made the presidential candidate pledge to double the funding for AIDS. So when the president was elected, the funding was actually doubled. And it's also important to embed yourselves in communities as leaders. And here you'll grow different skills and gain confidence, for example, in communication skills, learn how to work as a team, develop interpersonal relationships, and also network. So yeah, I would urge us to put ourselves out there and put ourselves in those spaces. So that's the end of my presentation today. Yeah. Thank you. Vanessa?
Thank you so much for that absolutely amazing presentation, Cheryl. We are now moving on to our question and answer session. So if you have any question for Cheryl, you can pop it in the chat or unmute your mic, and we are happy to take them. I think while we wait for questions, I do have one question from my side, and it's more personal concerning medical students in Kenya. And so, how do you think the lack of global health initiatives and lectures within your university spaces impact medical students that eventually go on to become doctors? I hope my question is clear and can repeat it if necessary.
Sorry, could you repeat your question kindly?
Yes, it's how does the lack of global health initiatives and lectures within university spaces in Kenya impact medical students that eventually go on to become doctors?
So on that, I'd say in Kenya in general, or our education curriculum is very patient focused and clinical areas based. So students don't have other skills or see more than outside the clinical space. So I think it's important to have initiatives like this that educate students and show them that there's more to medicine and there's more that they can use their degree for than just being in the clinical space. Yes.
All right, thank you so much for your response. There's a question in the chat that asks, I just wanted to ask about your opinion on health financing in the Kenyan context. Is it primarily a matter of allocating more money to health, or are there specific aspects required?
Okay, I think that on the question of health financing, I think Kenya has money. I just think that it's being misused. And I think obviously we need to generate more income as a country, but if it was used better, then we wouldn't have they'd be, how do I call it? There'd be a lot of progress in the healthcare field. Yes, if the finances were used appropriately, and yeah, if they were used appropriately, that's it. So it's really important to tackle the issue of corruption and have leaders or have us as next gen leaders who have integrity and stand on values that and really want to see the best for Kenyan citizens. I hope I've answered your question, Vanessa.
Thank you for your question, Vanessa. I see, Walile, you have your hand up. You're free to ask your question or type it in the chat.
Yes, thank you so much for the beautiful presentation. So my question to you is that if you had, I'm sure you had noticed when Vanessa was introducing the initiative, it is co-led by students, and we are fortunate that we have the supporting staff, from Professor English. So I wanted to ask that in your space, it's very good to know that you are aware that there are spaces like this that students need so that they can broaden their skills. So what are the challenges that you think you may face or you are facing in establishing such initiatives?
I think that question Vanessa would answer better than I would. So I think I'll hand over one to her. Yeah. If you're okay with taking the question, Vanessa.
Excuse me, am I audible?
Yes,
Yes, you
Vanessa,
are.
I can, yeah.
Thank you. I'm sure Cheryl can add on after I've given a brief from my perspective. But I think just in terms of establishing student-led initiatives, often a challenge is that students don't actually see the greater need for such initiatives. I think because of how our curriculum is structured and what emphasis is placed on within our context. So it's always like there's always a greater clinical focus than there is about other aspects, which makes it a challenge. And I also think another aspect is that students also, because of the way things are structured, there's often not enough time. So people don't actually see value in things like this. I think, yeah, so there's just apathy. And I also think just because of how things are structured, there isn't enough focus. I don't know if it's the same within the Kenyan context, but I think Cheryl, you can like comment on it.
I definitely agree with you, Vanessa. I think people don't see just how important these things are. But if I'm to testify for myself, everything that I've said today is something that I've learned in the past for webinars. So I think it's important for other students to just see how important fora like this is. Yeah.
Thank you for your question, everyone. Our next question is from Jeremy Ali. They ask, are there spaces where we can learn or develop our critical thinking skills / communication, given that it is not in our curriculum?
So for that question, I would say that the internet is your friend. The internet is your friend, and a lot of this information we have at our fingertips these days. So what I'd say is it's important to create a self-development plan and note the skill that you want to learn and find different resources that can help you learn it. Yes, that's what I'd say. But the internet is your friend. Yeah.
Thank you for that. Our next question is, what is the name of the organization that funds the health sector? The one that should give 12%, but are giving 4 to 6%. I'm not sure if the question is clear, Cheryl. I can ask for them to retype their question.
So the treasury, okay, so the one that gives the 4 to 6% is it's 46% of the national budget. So this is taken care of by the treasury. Yes. It's the one that disperses funds to different ministries. Yeah. Then we have it's opposed to the Kenya Health Sector Strategic Plan, which says that we should use 12% of the national budget in healthcare, and the Abuja Declaration, which says that we should be using 15% of the national budget on healthcare. Yeah. But the treasury is what dictates how much is spent in different places.
Thank you for that. Our final question is from Dr. Kapanda. He says, thank you for your presentation. If you were to finish your training and be absorbed into the healthcare system, how would you support and strengthen the healthcare systems that will be your priorities in the almost collapsing Kenyan healthcare system?
Mm, For me personally, I think getting into a space of leadership or getting into the global health space and the space of leadership where you can actually make a change rather than just being on the ground. Because at as of now, many positions in the health sector are held by people who are not healthcare workers. They're not doctors, they're not nurses. They don't have, they're not aware of what really happens on the ground in terms of healthcare or provision of healthcare. So we need way more healthcare professionals having these positions. And I think for me, I would it's I would definitely look into the leadership side of healthcare. Yes, so that instead of having to run away from it and doing, say, exams to leave the country, it's more, for me, it's more about how can I help the citizens who remain here, because not everyone has the opportunity to leave like you do. So yeah, that's what I'd say. I hope I've answered your question.
Fantastic. Thank you again for such a lovely presentation, Cyril. I think that is all our questions for today. And we will now be moving on to our next speaker. But again, thank you for your presentation. Thank you for the Kenyan perspective. And I hope that you continue to join us in this beautiful initiative and that it spreads to Kenya so the students, they can also benefit um, from the collaboration of students and professionals alike. Without further ado, I'm going to invite Vanessa up to introduce our next speaker for today. Apologies, she's facing some technical difficulties, so I'll go ahead and introduce our speaker for tonight. So, everyone, I have the honor of introducing Dr. Lynn Hendricks. She has been a lecturer in the Division of Health Systems and Public Health at the Faculty of Medicine and Health Sciences since 2015. Dr. Hendricks is a transdisciplinary researcher with a PhD in both social sciences and public health that was supported by the VLIR URS. She is in 2023, a Springer Nature Inclusive Health Research Awardee and a 2023 Cochrane Thomas Palmer Awardee. She holds a keen interest in co-creative research within communities and works with digital mediums as well as primary arts-based methods. Her recent work includes a co-producing a local and international public art exhibition with the Zika Museum and a community-led documentary, More Than a Pill, with a young woman perinating infected with HIV in Cape Flats. Her Global Minds PhD project, entitled More Than a Pill, producing the story of adherence to ART for young women living with perinatal HIV, won at the inaugural Inclusive HIV Research Awards in Brazil. This project was a collaboration between KU Leuven and Stellenbosch University. Ladies and gentlemen, without further ado, I'd like to introduce you, Dr. Lynn Hendricks.
Good evening, everybody. I'm having some challenges with my camera. It's not wanting to show, but I hope it's okay that I just use the screen share option.
That's perfect.
Just give me a second to share. All right. Thank you everyone for having me on this evening. You guys are doing such fantastic work. And the first speaker was just amazing. It's so fantastic to hear the work that you have been doing. I'm going to be talking this evening a little bit about bridging the gap and how we translate knowledge and research into community health improvements. So I'm going to do that by maybe just going over some key concepts in knowledge translation, then sharing with you 1 or 2 case studies, and then speaking through some of the strategies. But I really would love to hear from you more than anything around the questions you may have, or things you have wondered, or maybe ideas that you have for future ways that you can translate knowledge. So in our world, we've got 2 key terms that we usually speak about, the one being knowledge translation and the other being science communication. And these actually have 2 really different functions. And hopefully my images can show you what I'm trying to explain in the difference. In the one side, we have knowledge translation, which purpose is to do. It's trying to take what you have learned and what you have done and make changes with it. So change policy, change practice, and use your results in a really action-orientated way. So you found something, you've discovered something, you found an intervention that works, or you have done a project at the clinic, or you've seen a gap in how things can be done better, and you do a research project about it. And now you write to the clinic and you say, you know, actually what we found is that this is going to make the system work better. That's knowledge translation. When it comes to science communication, here we are thinking about informing and awareness raising. So in science communication, this is where we take what we have learned and we share it with others just because we want them to know. Okay, we don't expect them to do anything about it. And each of these have really large bodies of work that go with them. So you have people that do knowledge brokering. So their whole job and what they do is take what you've done and create actionable priority things with it. And then we have science communicators who formulate the best ways for different audiences to understand what you have found. So the one is to do and the other is to inform. With knowledge in research, we usually use it in 3 ways. Either we apply knowledge, so here we really want to use it to make decisions. So this webinar is an example of applying knowledge. It's basically sharing and talking and discussing together. We can also produce knowledge. So this is where we do research, where we analyze, we evaluate, but we produce it, we're making something together. So if we were to write a report about this and what we have learned, like the first speaker analyzed what's been presented, that's producing knowledge. And then the third is brokering knowledge. And in this example, you are taking the evidence, taking the research, and making it more accessible to bridge the gaps between knowledge and what we can do with it. So knowledge for impact. I like to say that every scientific breakthrough in health and research findings can lead to significant community benefits, but only if it is effectively translated into actions that fit the local needs and contexts. So you can have amazing research and it can just go into a publication and no one can ever read it. Or you write a wonderful thesis, or you write an amazing research project that you do in 2nd year, 3rd year, 4th year, or see amazing projects that the students are doing in the clinics. But then after the assignment, that project goes to die on Sunlearn because no one's going to see it again. But there are some really key things that are valuable in your assignments and what you do that can have a significant benefit for the community. But to make that bridge between what you're producing and the change that you can bring, you have to translate it in a way that fits local context, responds to needs, and is a digestible format for the audience. So if you're doing research on something that's not important for that clinic at this time, it's not going to be prioritized. But if you are doing something that responds to a community need, the clinic is going to be on board and they are going to say, thank you for sharing this with us. Do you have ideas on how we can use it, on how we can implement it? So in knowledge translation, there is something that is called the know-do gap, which is the bridge between what we know and what we practice. A lot of the time we practice things that we know can be done better, but because of different reasons, which we're going to talk about now, we continue doing the same thing over and over again, even if it uses more resources, even if it takes more time, even if there are better technologies to support us, we still continue in the traditional ways of doing things. So this no-do gap is something that we really have to think about, and it's what we are going to consider now in this webinar. So there are multiple causes of the no-do gap. The first could be that there's a lack of awareness or a lack of access to the latest research findings amongst practitioners and policymakers. Policymakers are not reading your dissertations. They are reading the newspaper, they are reading the issue briefs that come to their desk, they are reading key things that people are presenting at meetings, presentations such as this one. This is where they are getting their information. And if your research hasn't made it to those platforms, they don't know about it. It's our responsibility as research practitioners to put the information out there. The other thing is about access. There's a big push in the scientific community for open access policies, but still that is problematic because to publish an open access article costs in the region of 1,500, 2,000 euros or dollars. And unless you have research funding, you can't actually publish in these open access spaces, which again puts a limit on researchers in the global south. There's also relevance and applicability. So again, you might do research that doesn't really apply to your specific context or your target setting. And that's why it's especially important that when you think about research projects, that you think about projects that are applicable and contextually relevant. You invest a lot of time and energy and headspace into the research projects, make it relevant. There could be insufficient skills and training. So maybe the research says we need to capacitate healthcare workers in mental health, for example. But then there's nobody to do that training. So then the no-do gap gets bigger. It's saying I must do all of this stuff, but I don't really have the resources to do it, which brings us to the next one. There's a limitation on resources. So we know what we should do, but we can't. There are also cultural and social barriers. So there's a lot of conversations around how we blend traditional and African-centered medicine practices with Western medicine practices. But there are just some things that don't work. It could also be because of patients, because of their beliefs or their cultures or their values that they don't want to adopt or accept new practices. And then there are policy frameworks. So as much as you want new research to make impacts, the policies don't allow. Also, the policy cycle is so long. So you can make a suggestion now. It can be discussed. You can go through the policy amendment phase, and 3, 4, 5 years later, now the framework has changed. Okay, so it's not immediate. So these are just a few, but there are multiple reasons for the no-do gap. So what I wanted to do now is show you maybe 2 case studies, how we used research to make community impacts. And then we will briefly look at some strategies around how we address the no-do gap. So the first project I want to share with you is a study I did with young women with perinatal infections of HIV. And this study started with systematic reviews. So originally I did a couple of reviews, so I think 3 or 4, and I identified a gap in the research in terms of evidence available for young people with perinatal infections of HIV. Using that information, I designed a primary research study, but I integrated the research from the systematic reviews and the primary studies, and then worked with community members to implement changes at the clinic. So there were multiple steps in this process. In the first step, I identified the gaps, and I call it stories. I call all my research stories because we're storytellers. So I identified the need for the story, identified the research gap. Then I started looking for additional stories, and I was searching and I was looking for them, and I found them in primary research. I then did a storyboard. So I crafted an artistic piece around what it means to live with perinatal infections of HIV. I then used that to triangulate the data with primary research in the field, so with actual living patients. And then using what we did, we restored this information into a way that could be consumed by policymakers in dialogues. So those of you that have done a systematic review before, usually you present this PRISMA flow chart, which tells you where you conducted your search, how you went through the process of screening, and how many studies you were left with to include in the systematic review. So in this example, we searched over, and in our search, we received over 1,000 records that we searched through and went through a whole screening process. And ultimately, we included 47 papers in the systematic review. This QR code is a link to the publication. This is the artistic storyboard that I did to analyze my data. I know it's not the traditional way of doing analysis or a literature review, but this is how I choose to do my work, and it works for me. It's called storyboarding. And I published that storyboarding picture into a publication. So I guess other people like it too. I then took that storyboard and I took away all the text, and I spoke to young people and I said, which of these pictures relate to your story? Tell me which of these stand out for you. Are you drawn to the girl? Are you drawn to the pill bottle? And they took their sticky notes and they started adding their stories onto the systematic review storyboard. We then did some photo voice. So we went to the clinics, we did research, we made a documentary out of this. We collected items in the clinic that stood out for them, that made them think about the experiences of living with perinatal HIV. Here you can see the printed tablecloth of my storyboard. And then we took all of this information and we repackaged it into a documentary. This documentary you can look for on YouTube. Here's the QR code. And what we did was we had a movie screening at the university. I think this was in 2022. And we invited policymakers, community members, clinic managers into this dialogue. And they could talk about how they could support young women in their environment. So how can policymakers support young women? How can clinics support young women? How can parents, how can community members, etc., etc. We also did an art exhibition. So these are some of the artworks that I made with the young women that people could view and engage. They were touching the data, they were touching the research, they were feeling, they were looking, they were experiencing it. And it made a big impact. So much so that we have enough data to make another documentary where policymakers speak about their recommendations based on the study. So the impact was local in that the clinic setting became more aware of the experiences of patients. They adapted how they offered their services to the patients. The patients had a community network of participants that they didn't have before. None of them knew another participant with the same story, and they all went to the same clinic. So they met one another. We innovated new research methods, and we also developed a new theory that we are now testing in other theoretical health projects. Another example is this teenage pregnancy abortion project we're working on in Bishop Lavis. And here, this one is completely community-led. We engage with the media, we're using a creative arts festival, we've got a social media health campaign, but we are making an impact in how schools work with grade 6, 7 learners who are pregnant, but also learners to prevent preteen pregnancy. So through these examples, I mean, there are so many strategies, but I think for now, these are the most important ones, is for us to address the no-do gap. And that is through developing knowledge translation frameworks. So in your project, think about what is going to be my knowledge translation strategy. How am I going to use this information to make a change? And not all change has to be big. You can make small changes. That is still a change. It's still impact. How are you going to address stakeholder engagement? The more people are engaged from the very beginning, the more people are going to be open and flexible to the suggestions that you come up with together. You also need to think through capacity building. So it's not enough to say, I want to do this, and I want to do this with people. How are you going to capacitate people to do these things? So this organization that you have now, the network, is an example of capacity building. We're already bridging the no-do gap here through this experience. We need to think about policy advocacy. So when do we take what we found and we move it into the policy arena, and how do we do that? And then also piloting projects. This is so important. A lot of the time we just wait for research funding to do large scale projects, but there is room for smaller pilot projects to show feasibility of the studies, which you can do with very little money. And it also provides that extra foundation that you need for when you apply for the bigger grants. So I'm going to wrap up there by saying the no-do gap does exist. There are lots of barriers, but there are innovations and creative ways of bridging that no-do gap. And I do believe that younger generations of doctors have the technical skills and know-how to have a larger reach compared to how research has traditionally been done. So I'm going to end there. Thank you, Vanessa and team. I'm going to stop sharing.
Thank you so much for that wonderful presentation, Dr. Hendricks. I think I can speak for everyone when it says, when I said that it's beautiful to see how research could come alive through your work. And I'm sure it's inspired many people to get involved in research and see how their research can become tangible. I'm now going to open the floor to any questions that anyone might have.
I have a question. So thank you, Dr. Lin, for that presentation. I just want to know or ask, how can we get our research to policymakers? How do we involve the policymakers as well in the research process? How do we get access to them? Because a lot of the time it feels like they're out of reach. Yeah.
Exactly. And you know what? It's because we've always been taught that we have to access policymakers who are working at the very top. But what I did with my research is I accessed, because I used to work in government and I used to run research programs. So I know how people work together. But when it comes to community-focused research, you don't have to go to the Minister of Social Development. You can go to the ward councillor, who is a local politician, a local community leader, and you can work with them in designing your project. Even if you just have a meeting and say, I would like to do this in the community, what do you think the challenges are? and they will get involved. That's what happened in my community project. He championed my project from the beginning and then connected my project with other community leaders. So I think redefining who the target policymaker is really important. Don't be afraid to go to the local office. They are always open and 100% more accessible than people who are sitting in parliament.
All right, thank you.
Thank you for your question, Cheryl. If there are any more questions, feel free to either unmute yourself or type it in the chat. While I wait for that to happen, I have a question for you, Dr. Hendricks, and that's more so for the continuation of research the students do. So from Stellenbosch University side, the new curriculum enables us to have various interventions and collect data and measures that we implement within the various clinics in the Western Cape. My question is, how do we enable continuity with the already established initiatives that students bring to their local clinics? Because a lot of the time, as soon as the assignment is done or as a new group is placed, a lot of the initiatives that are community-based end up dying as the students leave. So is there a way we as students can contribute to the continuation of initiatives that we start in our community clinics?
Yes, that's a really good question, and I think it's so relevant. So one of the ways that you can continue is, is exactly with an organization such as yours, the network. When you have students maybe coming in that are in junior years, you can discuss with them taking the project forward. Also, I think making sure that you speak with the clinics and the community that you are working in once you have done your research. There's nothing stopping you from continuing to work with that clinic, even though you have moved on. You can also think about translating your information. You can make YouTube videos. You can post things on your LinkedIn. You can write blogs. You can share your information at conferences like the annual academic year day. You can speak to lecturers and people working on the primary platform about a project, especially if you found something really interesting, to assist you to apply for social impact funding. I think there are lots of opportunities. I know there's one student who's working with an external organization on a diabetes project in Delft, and they came across that project 2 years ago when they were placed there. They are still working there. And it's a group of them, and they continue to add students to that. So I think reaching out as a first prize is really important. All hope is not lost. It's really about just talking to people and finding out how you take it forward. Do you mind, Vanessa, if I look at the questions in the chat?
Yes, I was just about to read a question from
Okay.
the chat. There's a question that asks, I just want to thank Dr. Lin for the presentation and highlighting the importance of not just finding the problem, but putting forth the necessary research to make necessary stakeholders who sometimes have the upper hand resources wise, and the necessity for capacity bringing changes, therefore. I think that was just a comment. Then there's a question from, I apologize, Vanessa. She says, my question is about the practicality regarding research. How would you recommend novice researchers start their research journeys?
Oh, that's a very interesting question. I'm trying to think how I started mine. So I just was really interested in research, and I would always I would always find a way to ask questions. I would read a lot, but I think the key when it really took off was when I started connecting with people. So I would reach out and say, I'm really interested. I want to learn about research. Do you have things that you are doing that I can help you with? Are there meetings you're attending that I can go with? Are there things that I can do in and around your office? I mean, that's what I did. I just hung around people's offices. I read, I took notes at meetings. I said, can I please go with you to this meeting? I will take notes for you. I just volunteered my time. And I also volunteered to work on research projects. So there's a really interesting organization in Cochrane. I don't know how many of you know about Cochrane, but there's something called Task Exchange, where you can sign up for tasks that are on the website to participate in different research projects. So somebody will post there, I'm looking for someone to do screening with me on the systematic review. So there are opportunities. There's also the Students for Best Evidence Network, who also post tasks. But for me, it's just about connecting with people and networking. And if you find, like, Google stalk people on LinkedIn that work in areas that you're passionate about. Internet stalking people is super essential for research creation. Find the people that are working in your interest areas and reach out to them. If you reach out to 5 people, 1 person is going to reply to you, where you are going to be able to connect and find something to do.
Once again, I just want to thank you, Dr. Hendricks, for a fantastic presentation. We have now come to the end of our webinar. If there are any pressing questions, you have 2 seconds to unmute your mic and ask. All right, well, that brings us to the end of our webinar. Again, I hope that everyone takes what they've learned today and put it into practice in their various countries and spheres. And again, a special thank you to both the speakers for having us today and giving us fantastic presentations. Thank you, everyone, and have a great evening.
Thank you so much. Have a good evening, everybody.